Good morning, everyone. Happy Friday. Welcome to today's Ethnic Media Services News Conference. I'm Sunita Sarabji, the health editor at Ethnic Media Services, and your moderator today. A new hybrid COVID variant, XCC, has dominated in 25 states in the US, and experts predict it will cause a surge of COVID-19 cases this fall. Updated mRNA vaccines, including the Pfizer and Moderna, are now available along with the reformulated Novavax. But are the new vaccines able to detect and protect against XEC? Speakers this week will discuss the new variant, the updated vaccines, vaccine hesitancy and weariness, and explain low vaccination rates in Latino and Black communities. They will also debunk misinformation emerging from Florida about the inefficacy of the mRNA vaccines for older adults. Our guests today are all familiar faces who have helped us make sense of this pandemic over the past 4 years. They are Dr. Benjamin Neuman, a professor of biology at Texas A&M University, Dr. Peter Chin Hong, infectious diseases specialist at the University of California, San Francisco, and Dr. Daniel Turner Lloveras, co-founder and CEO of Salud Contec and the Latino Health Innovation Alliance. We are deeply honored to have all of you here today. So we're going to have a panel discussion this morning with an initial round of questions from me, followed by questions from reporters. Reporters, please enter your questions in the chat, and I will take them throughout, even as I ask my questions. We'll try to get through as many of your questions as we can. So we begin with Dr. Chin Hong. Dr. Chin Hong, please explain the characteristics of XCC and whether it is expected to be the dominant strain this fall, how it differs from previous variants and subvariants. Is it more contagious, and what new symptoms, if any, are associated with XCC?
Yeah, so thank you, Sunita. And hello, everybody. XEC is a recombinant variant, so it just takes features of two other variants. In this case, there's one variant we haven't heard about called KS 1.1, and then the other variant is called KP 3.3, which is kind of related to the KPs that we've been seeing dominant. So when you bring two together, you bring features of each of the two variants. For one of them, we know a little bit more, which is the KP1, because it has this mutation called Q493E that allows the cell to just kind of bite onto the host cell and not let go. So it probably leads to more attachment. And then the other one called, the other variant has this, the other part of the two coming together has a mutation called T22N, and we don't know a lot about that. But essentially, the reason why people are paying attention is that it seemed to rise up the charts in Europe, particularly Germany, where it's about 13% of cases, the UK about 7%. And in the US, it really hasn't hit that 1% level yet. But all our rates are going down. So it's kind of waiting in the wings. And because it's rising up the charts, that's why people think it may come here. But to me, it may not be XEC, but XEC is a metaphor for something that might come in the winter that may be a little bit more transmissible. So that's the reason why we're paying attention to it. The other reason is that, it's a recombinant variant, but we shouldn't be scared by that because it has word X in front of it. We had one in 2023 called XBB, and that was something that also was similar in that being a recombinant. So that's kind of what we know. We don't think it's going to cause more serious disease because the population immunity is generally high. The most important thing is to get a vaccine, and we think you'll be well protected against serious disease, hospitalization, and death. But the match of the vaccine, and Dr. Neuman will get into this some more, may be related to how long it will help buffer you against just getting infected in the first place.
Interesting. And are there symptoms associated with XEC, such as when we had one variant, there was pink eye associated with it? And I'm sorry, I cannot remember the subvariant with which pink eye was associated.
Yes, so far we don't know if there are new symptoms or strange symptoms, but I think in general, over the 4 years, we've been seeing more diverse symptoms with COVID as people have different degrees of immunity. I think one that has gotten attention this year is gastrointestinal symptoms in general, because people don't normally associate diarrhea or nausea or vomiting with COVID in the absence of sore throat or congestion. But there have been more cases of those people with COVID. And in general, what has been seen is the usual symptoms of sore throat, congestion, headache, muscle aches, and in some people after a few days, shortness of breath and some of the symptoms that enable people to go to the hospital. And that's what we're trying to prevent.
Interesting. So Dr. Chin Hong, just a follow-up question, what is the dominant subvariant that we're looking at here in the US right now?
So it's called KP 3.1.1, and it's responsible for about more than 50% of cases. But to step back, all of these are Omicron still. So we're just talking about changes within the Omicron family. We're not going from Alpha to Delta and Delta to Omicron. It's still all within Omicron. Omicron has been wildly successful in just staying within that family because they've kind of figured out what to do to stay in the population, transmit itself without, very successfully and keep on mutating within that family. And they're all sort of related to JN1, which is a parent. And that JN1 was what we saw last winter. And these are descendants of JN1, which is, again, all Omicron.
Fantastic. Reporters, please enter your questions in the chat, and I'm going to take them even as we go through this initial round of questions. So we move to Dr. Neuman. Dr. Neuman, could you please discuss the new, the updated mRNA vaccines and the Novavax? Do you believe that they are effective against these new subvariants, and when should we be taking them?
In a sense, it doesn't matter what I believe because they presented very nice data to the FDA, and it's there for anyone who wants to go and look at it. You look at the Vaccines Advisory Board meeting schedule, you look at the June meeting and scroll down to the materials. They're right at the bottom. Look for the presentations that are by non-FDA parties, and those are in order from Novavax, Moderna, and Pfizer. And you can get all the data firsthand, and you don't even need to rely on experts. But yeah, it looks as though these are a much needed update and a good update. So there are two things that we need to update. One is the antibodies that are going to protect against infection, and this is very important for updating antibodies. If we're looking at this from a purely scientific point of view, the average half-life, if you like, for the vaccine, or the amount of time that these vaccines actually protect against new infection, is only a little less than 6 months, and usually more like 4 months. And that's only because the virus changes. It's not because the vaccine is bad or anything like that. So if we were approaching this from a scientific point of view and not taking cost and all these other things into consideration, probably the FDA should be updating this vaccine twice a year rather than once a year to get us to a point where you could actually take a vaccine and have a reasonable certainty of not getting infected throughout the year. As it is, there are two options. The two mRNA vaccines are essentially the same. They appear to use the same version of the same strain. And there's the Novavax. So Novavax is a protein vaccine, and I believe it takes a little bit longer to make. You're essentially doing farming in order to produce these things. It's molecular farming. The Novavax vaccine is against an older variant called JN1, and the version that they appear to be using would have peaked around March of this year. And it's been more or less extinct since the summer. It got replaced by those flirt variants, which are also known as the KP variants. The two mRNA vaccines are a little more recent. They're to KP2, which was one of the dominant strains over the summer. That peaked around June. And that is a lot closer to the virus that we see now than the JN1 is. So if you're looking at the amount of time that you are likely to get protection based on the rate of virus change, not the rate of anything to do with your immune system, you are likely to get more mileage out of one of the two mRNA vaccines only because they're a little bit closer in time to the virus that is circulating now. No one knows what the future will bring. If the virus decides to make a left turn and go back to something more like JN1, then the Novavax vaccine will be superior in terms of protection. The other thing, though, to consider is that for many of us, it may have been a year, 2 years, 3 years since the last time we were vaccinated or infected. And initially, we weren't sure how long white blood cell immunity or T cell immunity would last. Now there are signs that at least in some people, it is only lasting maybe 2 or 3 years. And so there would be a lot of people who would potentially need a top-up of the vaccine for that reason. Mm-hmm. This is not like your childhood polio vaccine, where you can take a dose and then relax for the rest of your life and get on with business, only because we are constantly bombarded by this. And immunity doesn't last only because the virus changes a little too fast for our immune system to catch up with, unless we vaccinate. So I would say if there are people who are planning to take the COVID vaccine, it's important not to wait on this one. By the time we get to next spring, I don't know which variant is going to be dominant, but it's probably not going to be anything particularly close to either of the vaccine strains that are here right now. Taking the vaccine now gets you through the holiday season, hopefully without any damage to you or your loved ones. And I think that is definitely a price worth paying, at least for me.
Absolutely. Dr. Neuman, I'm going to hold you to a specific point that you made. You were concerned about the efficacy of the Novavax vaccine when we spoke earlier. Could I ask you to amplify your comments on that?
Yeah, absolutely. So there may be people whose doctors tell them they need to have a protein vaccine for some reason. And your doctor would know, presumably, a lot better than I would anyway. For everybody else, what you would be getting with Novavax is a much older version of the virus. You're essentially vaccinating with something like a fossilized strain, and you will have less durable protection just because of how much the virus has changed since then and how much it's probably going to change in the future. The rate of change is predictable. The direction of change is never predictable for these. So I would say if you're looking at what gets you the most bang for your buck, it would be one of the two mRNA vaccines, and they're functionally identical.
Thank you. Dr. Turner-Uveras, vaccination rates are extremely low for Black and Latino people, but you believe this is not just vaccine wariness, but actually an inability to get the vaccine. Can you explain some of the barriers to getting vaccinated and how your organization, Salud Contec, is working to get our most vulnerable folks vaccinated?
There we go. I wasn't able to unmute my microphone. Appreciate it.
There you go.
Thank you. Buenos días a todos. And thank you for having me. And I thank you for asking this question, since it's an important topic, and it's a topic where the answers really have not changed much since the beginning of the pandemic. When I have to start off by saying that when we talk about COVID-19 in communities of color, what we're really talking about is access, trust, and equity, right? These communities aren't just hesitant. they've been overlooked, and there have been victims of misinformation, disinformation, just like many other communities, right? And people want to protect themselves and their families, but the barriers to the vaccines are real, as well as the barriers to reliable information about the vaccines. And so it's easy to look at the numbers and think, why won't people just get vaccinated, right? Like, why won't they just accept it and see for what it is? But if you're in a community where transportation is an issue, where there's only one clinic for thousands of residents, and where language barriers make accessing information difficult, where if you go to a clinic, everything is essentially in hieroglyphs, it's very difficult to be able to accept that vaccine since you're not familiar with it, and the information coming to you is not as reliable and saying things that are not trustworthy. And for people who've been historically mistreated by the healthcare system, we can't ignore that this mistrust plays a huge role. And that's why we're taking vaccines to the community. And that's why I think vaccines still need to be just like a pandemic, where mobile distributing them so that they're easily accessible, where there's pop-up sites. I've seen some of those going away, but I think they're still important because access. It's a continuing problem that we've gotten better at. And I think because we've now looked at it through a different lens, and we now appreciate the importance of having access to these vaccines and also access to reliable information. But as you know, many of these barriers still exist, and the more we talk about it, the more we can put it in under the microscope, under the health equity lens, and really drive more locally community-driven solutions.
Absolutely. Vaccines are no longer free. Is cost a barrier?
Definitely. If you're in a community where the average median income is at poverty level, money is always an issue. And there have been some new socioeconomic interventions, I think, that would make accessing the vaccines easier. But the fact that now having to pay for it is just another barrier. I mean, we're all familiar with the cigarette tax. The cigarette tax was essentially the most effective public health intervention we ever had to decrease smoking. We know that when you have to pay for something, it has an immediate effect and has a very measurable effect. And so I think if the goal is really to increase vaccination rates, then we might want to reconsider the charging for the vaccine, or develop some type of program where it makes it easier for certain populations to pursue special programs where it can be paid for.
Absolutely. Michael Fitzgerald, you had a question which Dr. Neuman answered, but could you ask your question live so that we can have all our folks get to your question?
Okay, can you hear me on there?
Yes.
Okay, my question is about the tests. I know that there was some question months ago that the tests that we had all received, or many people had gotten from the government some time back, were no longer necessarily efficient for the virus at that time. I wondered if the new tests that I just read about, that are being apparently free, if those tests are going to be able to detect the new or the latest variants.
Good question. Dr. Neuman?
Sure, yeah. We think probably yes. So I've tested out some of these kits personally, and they still seem to recognize the virus. It would depend which one, and there may be batch-to-batch variations, so I can't say a blanket, it'll definitely work, but most likely yes. The part of the virus that the tests look for, and both the PCR and the antigen tests, those little white bricks that they give you, those are both looking for the nucleoprotein, and they're looking at one or two regions of that protein, which is part of the virus, and it doesn't change. It's not a part that's on the outside of the virus, so there aren't any antibodies or immune response that are driving that to become different in order to survive. So it seems to be fairly stable, and hopefully they should work. Yeah.
And Dr. Chin Hung or Dr. Turner-Uveras, would you like to weigh in?
Yes, I mean, I would only add to Dr. Newman's excellent explanation the fact that it depends on when you test as well. So if you test too soon, you may not have enough virus to be detected by the test. And that's because, your immune system is active already for most people who've seen gotten infected multiple times. So you're probably sounding the alarm in the body earlier than the old days. So you feel sick earlier before you have a high enough viral load to be detected. So that's why you don't want to stop at one negative test. If you still have symptoms, you probably want to do another one in a day or so. So that's the only thing I would add.
Absolutely. Renee Barbie has a question. Renee, could you identify your news organization and who you'd like to answer your question?
Yes, thank you. I'm with Law and the Way of Voz, which is Pomona's only community newspaper. And a lot of my friends and family are refusing to get the vaccine for the new variant. They believe it's going to either cause them to get really sick or could possibly pass away. My doctor suggested I get the RSV shot and the vaccine shot, which I plan to do. But I mean, how do you convince people to get the vaccine when they are saying such negative things about it and they are afraid they're going to die?
Good question. Who would like to take that on? I'd like to hear from all three of you. Would you like to begin, Dr. Turner-Uveris? You're muted again.
Can you say the question one more time?
So I think Renee was asking about addressing vaccine hesitancy when there's so much concern about death as a possible result of taking the vaccine.
Right. Well, if you look at the vaccine, if you look at COVID-19 infection, every fear of a side effect from the vaccine actually occurs in the disease, except the only difference is the disease is 100 times worse. When I was at Harvard UCLA Public Hospital, front lines, first wave of COVID-19, I saw a 35-year-old man get COVID and had a stroke and could not walk like a regular person. That would not have, we don't see those types of things with the COVID-19 vaccine because you're going to have symptoms when you get the vaccine. That should have been very clear to everyone, but I think it was because of misinformation, disinformation, and also poorly communicated information that the COVID-19 vaccine will not prevent you from getting side effects of the vaccine and will not prevent you from actually getting COVID. The whole point of it is that you have an army of antibodies built up ready to protect you so that when the real virus comes, your symptoms are much, much less. And so whatever fear you have, whatever it is, whether it's blood clots, whether it's feeling ill, if you look at a graph that compares those symptoms from the vaccine versus if you didn't get the vaccine and you actually got the COVID-19 infection, the bar graph is just a gigantic big number and a small number. And so once you see it that way, there should be no hesitancy in getting the vaccine. The only hesitancy should be, why would I not get the vaccine? That would be the only hesitancy.
But just to follow up on that, Dr. Turner-Uveris, you're going to get symptoms which perhaps require you to take a couple of days off of work, for example. Right. For frontline workers, is that also a barrier to getting vaccinated?
Same argument. I would say same argument. So if I didn't get vaccinated and instead I just got infected, that time off would just double or triple. And so, yes, some people, I never needed any time off. I definitely had a sore arm, probably the most sore arm I've ever had from a vaccine. But that, in comparison to what I saw in my patients who are infected without the vaccine, it's really not a question for me. What is best and someone, what's the best decision to make? It would be the vaccine. And of course, I think everybody should take off the time that they need to recuperate. If for some reason they have a side effect that prevents them from their normal activities of daily living and daily working, they should definitely have that. And wherever they're working, they should provide that.
Thank you. Dr. Neuman and Dr. Chin Hong, how would you advise Renee's friends?
All right, let me throw some junk here and then we can finish up with somebody who knows what they're doing. So I see vaccine hesitancy as the new face of technophobia. When there are developments, there's always pushback. This is the pushback. There are powerful lobbying groups, including one fronted by RFK Jr., and these are specifically targeting the message that vaccines are unsafe toward minority, Black, Asian, Pacific Islander communities with disproportionately bad effects in those communities. I don't think they are necessarily doing this out of malice. They're wrong, but not intending to hurt anyone. It's just the side effect, I would say. Vaccines are here so that things don't have to be bad. You don't have to write longhand anymore. You don't have to walk over to your neighbor's house. You can text them. Not everything new is necessarily bad, and not everything old is necessarily bad either. It's just a change, and it takes a little adapting. So that's what I would say. This is something that we couldn't do before, and we can do now, and it saves you a lot of misery down the road. There are new studies in a type of monkey that show that when those monkeys get infected, even a year later, they still have some of the virus in the cells in their lungs, and it's still causing effects. Most likely, this is also happening in people, and this is probably what's going on with long COVID. So it's not necessarily a virus that you catch and get over. And it's just like the old vampire movies. The best thing to do is don't invite them into the house. Don't let them in the first place. Then you don't have to deal with the cleanup afterward, I would say. And now for a more sensible opinion, please.
No, I mean, you had me at vampire movies there, Dr. Neuman. But I really loved what both Dr. Turner Yuvaras and Dr. Neuman said. Really great perspectives. I would say that, first of all, my 30,000-foot view is that vaccine hesitancy, misinformation, disinformation is not a US phenomenon only, it's global. You know, I'm from Trinidad and originally, and I was speaking to somebody from the media there on this week, and the reason they were speaking to me is that the leader of the opposition, so riffing off what Dr. Neuman said about RFK Jr., the leader of the opposition was saying these facts that vaccine caused deaths, but she may have been using it for political gains. And it was really based on misinformation. And I think when you have people who are prominent saying these things, it's really uphill battle. We do know that the WHO cited vaccine hesitancy as one of the top 10 global health threats. So it is something that we're worried about. To me personally, with people, I try, like with everyone who disagrees with me, I try to approach that with curiosity and humble inquiry to find out what exactly is the holdup. Is it because somebody said so, or they just have a very some myth that I could easily dispel? So I think the hardest thing is to actually engage with somebody because vaccine hesitancy is so intertwined with political beliefs. I think sometimes these days we're so unwilling or feel afraid to engage with people. But I think in my experience, it's worked out over a series of times. It's like talking to somebody about quitting smoking. They may not want to do it in the beginning, but over time they might. So you might be surprised. I remember during the pandemic that when we went to San Quentin, a few of us to speak to incarcerated people about vaccinations. There were many myths at that time, and we talked about it, listened to people's concerns, responded to them in the same way I talked to you about. And at the end, somebody asked the people who changed their minds about getting vaccine to stand. And there were so many people who stood. It was really heartwarming to see that in a short period of time, people's minds could be changed. So I would say to believe in people's flexibility, even though some people may not be. and to, continue to, each of us can, in our own platforms, all of you in this audience is doing a lot by saying and emphasizing and holding up science rather than myth or politics as a way to, keep everyone safe.
Absolutely. Dr. Turner-Uveras, you've also done a lot of work with the prison population. Could you speak a little bit about that?
Yes. Right. The VEED program, our Vaccine Education and Empowerment Program, was the only program in the country where we were able to communicate with those in ICE detention about the COVID-19 vaccine. And if you think about any group that really had best reasons to not trust the COVID-19 vaccine, I would say I would give it to those in ICE detention. This is a prison that does not follow prison rules. Essentially, they really don't have to, they follow their own rules. We've tried to enforce basic human rights rules, and even with that, you have difficulty. And so they're really powerless, and they're getting the vaccine, receiving the vaccine from those who are supporting these inhumane treatments of them. And so the refusal rates were up in the 50, 60% at some of these institutions. And so we thought this would be a really a place where we would really want to have a conversation with people about what they feared about it, if they had any questions. And our the effect was huge. And we were able to also have medical students from USC Keck School of Medicine were able to join in some of the conversations, and they were able to see the profound. It's difficult to teach trust. It's easier to see it and witness it rather than describe it, since it's something that really is difficult to put into words. But you're able to see that in the beginning of the conversation, there's a just fear that's being expressed. And once you're able to have a conversation in a way that in their preferred language, where they can understand things better, since if it's a second language, I would not want to have a conversation about a vaccine in my third language, which would be something like French. I would be very afraid after that conversation, because I knew I would know that I didn't get everything. And you want people to get everything. You want people to leave that conversation with, okay, all of my questions are answered. And just by having all the questions answered, not just the vaccine, in life, anything you're considering, once you've asked all of your questions, you have a little bit of a different mindset about that question. It really has a tremendous impact, I would say.
Absolutely. Before we move on, could you each make a very broad statement about the politicization of a major public health issue? Dr. Neuman, do you want to start?
Sure. COVID doesn't care about your politics, so I don't know why your politics would care about COVID. This is just a condition like a rock falling on your head, and there is no political solution. There's only getting out of the way of the rock. Get a vaccine. Thank you.
That's great. Dr. Chin Hong.
I don't have as pithy statement to make as Dr. Neuman does, but I would just say that it's just really heartbreaking for me to see that politics has infiltrated healthcare, and it really just leaves minority populations further behind. Just like the way that misinformation targeting that population has a disproportionate effect on that population. And I would say it's, particularly as an infectious disease doctor, that something like a mask that we've used for decades in the hospital to make that a political symbol is very heartbreaking, and is really impeding our ability to take care of people right now.
Dr. Turner-Uveras.
I would say trust is not a given. It's something that's earned. And as of right now, the healthcare system has a lot of earning back to do. Vaccination campaigns should be personalized to the community and the language that they speak, and where they are, and meeting them where they are with the vaccines, and also with the messaging. What do I mean by that? I mean, Latinos are not a monolith. Most of the campaigns that were done in public health were translated into Spanish, as if there's only one version of Spanish. But if you've ever tried to speak Spanish to somebody from Cuba with strictly Spanish from either Mexico or Spain, it's going to sound a little foreign to them, but just because of the nuances and the small words. And so we really want to hyper personalize these communication messages, and also I would say the reporters have a tremendous impact on all of this. And I think it's also really important to not just report about the barriers, but also highlight the solutions. And that not always to focus on what's broken, but also to show us and everyone what's possible when we get it right.
Could you talk about some of the misinformation and disinformation that you're seeing out there?
Sure. There was, I think this was in a, this was covered in a news story, that in the Central California, there was a rumor that if you received the vaccine, and this was on a radio station, it was presented, it could change your gender. And this was taken very seriously, very seriously. And also I think we had cases where doctors were, and in my opinion, doctors, if you have a medical license and you're saying anything that's documented as misinformation, which essentially is now preventing someone from receiving a treatment, we can actually calculate what that means, like the number needed to do that with to cause one preventable death. And that's what they should be really, that's how we should look at it as. If you're changing somebody's mind from being vaccinated to not being vaccinated, you've essentially caused avoidable harm, which should really be taken seriously and be taken to a courtroom somewhere. But that's just my opinion. I know that some people don't feel that same way, but I think if it's proven false, not just an opinion, but just complete, like that one, like the one I just brought up, that is obviously, there's no way anybody can have any logic on trying to say that's true. We should be very, very harsh on those, I would say.
Dr. Neuman, Dr. Chin Hong, what are the most egregious examples of misinformation and disinformation that you've seen out there? Who wants to start?
Nothing as interesting as that. Perhaps Dr. Chin Hong. Yeah.
I don't know we can top that one, but I still hear some of the original myths still being circulated, like the vaccine is a chip in you from Bill Gates, or they rushed through the vaccine. I think one current update of they rushed through the vaccine is that the new version of the vaccine hasn't been tested, but it's just like the flu vaccine where you don't really need to go through all of that testing like you're starting a new vaccine, because the ingredients are the same. So the way I explain it to patients is that you still have the same brownie recipe. You might use a little bit more chocolate, but it's the same ingredients. So you don't really have the time with an updated vaccine every year, like the flu vaccine, to start from zero and to go through all that. So I think those are all things that, I think people needed to be reminded about.
So I think when we pre-briefed Dr. Neuman, we spoke about misinformation coming out of the Florida state government, which says that questions the efficacy of the mRNA vaccine for older adults. And you debunked that. Could you share that with us? Are the vaccines effective for people over the age of 65?
It was peculiar when the Florida Surgeon General came out with this statement a week ago or so.
Yes.
Because there was no new data which would suggest that anything that he was saying was actually true. The new data for the updated vaccines was collected by inoculating mice, and mice are not people. You can do tests on older and younger mice, but that's normally something you would do if you had more time. And what they're trying to do is show that the vaccine makes antibodies and the antibodies work against the current strains. And that was the quickest way to do it. And that's the way all three of the vaccines were tested. So there's no substance to this. Supposedly, the idea is that there is myocarditis in older people, but that has not been the case. The only cases where that was found, it was mild. It's in very young males. And there's been no literature that I'm aware of showing it happens in older people at all. From my perspective, if I was in a position of authority with an MD, degree behind me, I would find it unethical to say something that is contrary to what is known, science. Yeah, I can't speak for the Attorney General of Florida, though.
Dr. Turner-Uveras, myocarditis seems to be an issue amongst young Black and Latino men. How is your organization addressing this concern?
I would say it's not one of our focuses. If you look at the numbers, of course, there is enough to where it is a problem and should be addressed. But I would say it's not one of our areas of what we're putting more energy into. We're more focused on the more general fears, and I'm familiar with the disease, and I have seen patients with it, and I've even seen a patient go to the CCU for it. But in my eyes, it's not something that is such a great problem that it should be a focus of our interest. That's the only answer I have to say.
Dr. Chin Hong, many people are taking the COVID vaccine along with their flu shots. Would you advise for that or against that? And are people going to see more symptoms if they take the two concurrently?
So there's no evidence that you'll have more symptoms. To me, it's just about convenience. So for me, convenience trumps everything. So if you're going to Walgreens or CVS and you may not go back again, even if you don't want to go and get more chocolate or something that will make you go back there, get it both at the same time. If you are the type of person to be able to make 2 separate appointments for where you normally get vaccines, most people, if you have the choice, sure, you can get it at different days. But both vaccines are not hard to get in terms of symptoms. Generally, the shingles vaccine, for example, some people ask me, can I combine it with the shingles vaccine? And again, bring it down to convenience. But the shingles shot has a little bit more symptoms. But again, still important to get. So in that case, I would say space it apart. But for the flu and COVID, you can get it all at the same time. Convenience trumps everything. In fact, next year, we will probably have an option of a combination flu and COVID shot, just to tell you that it's safe and doable.
Fantastic. And what are some of the symptoms that we should be looking for post-vaccine? And when should we take our loved ones to the hospital if we see that they're experiencing those symptoms?
So I think the most common symptom in about 40% or so of people is just soreness at the arm. But for example, I feel lucky because every time I've gotten the vaccine, it just went in easily, and I didn't get any soreness like with some of the other vaccines. But other things that have been mentioned include fatigue, muscle aches, headache. Some people might even get fevers or chills. Many of the symptoms were reported in the original studies when you had one followed by the other one. So a 1-2 punch. And that's similar with the heart stuff too, myocarditis in the adolescent males. Most were after the second shot, because remember when we first roll out the vaccines, you get them like a month, 3 weeks to 4 weeks apart. And that, 1-2 punch might result in more robust of a immune response the second time you get it. So when you get in once a year now, you can still get symptoms, but in general, my experience has been, not as many people complaining about symptoms with this far apart interval. I would say the only other thing to mention is that when you take somebody to the hospital, I think if the fever doesn't go away, some of these symptoms may last 3 days. Some people have no symptoms. Usually a response before might predict how you'd respond in the future. If somebody is not appearing to be themselves, but again, we wouldn't expect that to be a side effect of the vaccine, like having loss of consciousness or altered mental status. And of course, when you get a vaccine, wherever you are, you get observed for a while to make sure you don't have anaphylaxis. But that was usually the first time around when people are getting it for the first time. You don't develop this kind of anaphylaxis all of a sudden. So if you didn't have it the first time, it would be very, very, very unlikely to have that, the third time you're getting the vaccine. So these are just some things to look out for. But in general, given how far apart the vaccines are now, you probably would see fewer people report symptoms after the vaccine.
And should children be availing of these vaccines?
Yes, I mean, the vaccine is approved for everyone over the age of 6 months. But I would say there are two reasons to think about vaccinating kids. One is that, particularly if they're school age and you want to get people through the winter when you have a lot of gatherings and Thanksgiving, and it does provide you a buffer against infection. So, your kid being sick will mean you're being sick potentially and you staying away from those events. So I think that's one way. The second is that to think about it, the second is that the kids everybody's interacting with the child. It's very hard to have a child with COVID and not take care of the kids. So I think it may put, depending on who your household is, more vulnerable people at risk. And then the third reason, I know I said two, is that kids also can do poorly with COVID. We know that, particularly in the respiratory virus period, that getting infected with one virus may put you at risk for others, and there's co-infection, and there are other viruses like RSV that are really more important for kids. So there are several reasons to think about kids, but again, one priority population is really those who are older than 65 and those who are immune compromised.
Dr. Turner-Uveras, I was looking at CDPH data before joining this call, and vaccination rates for Black and Latino children, looking at that, I mean, they're terrible. Could you explain why parents might get vaccinated but are not vaccinating their children? What are the concerns there?
Sure. And I'm an internal medicine physician, so I see only adults, but obviously familiar with all different types of cases. I know personally, and I'm sure everyone here, I think, also knows people personally that were vaccinated but did not want to vaccinate their children. And I think it comes from a good place of worrying about their children. And I think, especially in California, if you look at the common perspective of what people think about vaccines, California in general is more anti-vaccine in children's than maybe other states, and it comes from obviously a long history of distrust and also misinformation, disinformation mixed in with that. And so I think it comes from a good place that they don't want to give their child anything that is experimental, that they see as experimental. They're willing to use it on themselves because that's something that they see as something reasonable. Sorry about that. I had an announcement here that I didn't want to put on mute. But that's how I would see it, and it's something that can easily be overcome with information, with trust, and with sort of being consistent in the repeated messaging. Rather, you saw during the pandemic, our messaging was all over the place. 1 month it was this, 1 month it was that, and that really, I felt like that was a turning point where it opened the doors to having everyone else become an expert. Because once people started to look at the experts are not sounding like experts, the experts sound a bit confused. Now I'm starting to look around. And then once they start looking around, then the people who were not experts but wanted everyone to believe they were it was like they were waiting for that moment. They were like, yes, I am ready for this moment. And they just came with all types of information that was just nonsensical. And so I think that is a really important piece. And also that should be a part of education for providers, for doctors, for nurses, is influence. We used to be really good influencers. And I'm not talking about influencers. Most people think about the word influencer, they think of TikTok, Twitter, Instagram. Influencers are people who are respected because they're an expert in their field. And if they recommend something, it influences their behavior. And now if my doctor tells me I should eat less sugar, he influences me because I see him as an influencer, and I'm going to change my behavior because of his recommendations. That is now becoming more of a skill that can be taught, but I don't really see that being taught in many professional schools. But it may be something that we want to circle around on, since if we look back on during this pandemic, our public messaging and our influencer type communication skills were not where they should be.
And that brings us to a very good question asked in the chat. The public health messaging about vaccines has declined significantly, both on the state level and on the federal level. How can we get governments to commit to renew the messaging around vaccines and getting tested? Dr. Neuman, do you want to start?
I think we can start with me only because I think the other two guests will have much more informed perspectives. I think when you're dealing with large numbers of people and governments, I think there is a balancing act. And right now it looks as though they're balancing cost against COVID messaging, essentially, and COVID updates and things like that. And I think it's a cost-benefit analysis. From my perspective as a virologist, that is not what I would like to see, but this is why they don't let me make those decisions, I would say. I can think of much quicker ways to get out of problems like this, like the pandemic. I think the important message is that vaccines aren't forever. These are a stopgap. If you look at the vaccine we took against flu last year, it had 4 strains in it. This year, there are only 3 strains because we drove one of them to extinction through vaccination and masking. That is the goal. And when we get to that goal, there is no reason to vaccinate anymore. Right now, we're in a weird sort of limbo where some are, some aren't, some do, some don't, and a lot of people still get infected. Things could be better. That's what I mean when I say that.
Dr. Chin Hong.
I think that the one barrier is money, and traditionally public health has not received funding at the levels that they need to operate. And they're still not receiving a lot of funding because prevention, we are a very treatment-oriented society and not prevention-focused. Because prevention, you're successful when you don't see anything, and that's the whole point. In treatment, somebody has something bad like a rash and you treat it and it goes away and you feel, wow, you've achieved success. But it's such the warped way of thinking. So as a society, we traditionally don't spend a lot of money in prevention. As people know, the pandemic office was even closed before COVID in an ironic way. But that comes to your question. Yes, I think it's really important for federal and governmental agencies who are seen as potentially less biased than pharma, because I think the only ads we're hearing on the radio now or on TV come from pharma. So I think in people's minds, I get this accusation all the time, or you're only pro-vaccine because you're getting paid off by the drug companies, which is completely false. But if you're only hearing messaging from Pfizer or Moderna, I think, it makes sense that people associate those two things together. So we need to have more diverse messaging from different people and on different platforms. So fight that misinformation on social media, on Instagram, TikTok, and X, Facebook. People are trying to do that, but it's becoming a wilier thing than people have, are equipped to deal with. But it takes investment, and you not only get COVID, but you get measles and mpox and pertussis and avian flu, and all of these things have commonalities in creating that robust system that could respond to pandemics, both current and future.
Yeah, I saw some of the responses to one of the, I believe it was an op-ed that you had recently done, and boy, they were vicious. And do you want to continue to put out this messaging in the face of such attacks?
I don't read any of the comments. I mean,
Smart.
the few times that I've read them, I feel so distraught that I don't, it stops me from doing my regular work. So I stopped reading them, and I get, so yes, I mean, you do bring up the idea of hate against the messengers too, and that is a real thing, that's crossed racial and ethnic lines, and talked about me being in bed with drug companies and things like, which is completely untrue. But I've learned not to look at that as much as I could try not to. And emails too, because my emails are public because I work in a public institution, and lots of crazy stuff coming through.
Interesting. Dr. Turner-Uveris, what would you say about the government needing to put more funding into reaching specific communities, targeted information to, for lack of a better word, marginalized communities?
Sure. I would say if we really want to address that problem, it's not just about crafting better messaging. It's about building the infrastructure for long-term sustainable change. We need to invest not just in the research that produces the vaccines, but we need to support the community initiatives that are coming from the community, because whatever initiative that is, whatever messaging campaign that is, it's going to be effective, right? Because it's coming from the community where everybody trusts each other. And I think we need to put more funding into that, because if we solve that problem, that's a big piece of the puzzle. But that's something that we're not quite doing yet. Right now, most funding goes to, organizations or people who have a certain type of educational background, and they can then decide if they want to distribute that to the community. But I think we should really have, similar to what the HRSA grant did for the very first time 2 years ago, where they, for the first time, gave large grants directly to community-based organizations. And all of those had great outcomes, and I think we need more of that.
Thank you. Our final question comes from Sandy Close. What are the most important lessons we've learned about public healthcare from the pandemic? Could I ask each of you to address that question, and then we'll close this out? It's a broad question. Dr. Neuman.
Public health. When you actually practice it, it's mostly pushing numbers around and trying to talk to people. But boy, does it save lives. I have a lot of respect for public health and what they do and how they do it. And yeah, that was my personal lesson. I would turn to the other two for something more substantive.
Okay, Dr. Turner-Uveris.
Listen to the community. Real change doesn't happen to a community; it happens with a community. So those who know, those closest to the problem hold the keys to unlocking its solutions. If you look at it historically, and for the most part, we've been doing the opposite. And so I would say, listen to the community. Representation matters. People trust when they see their leaders that look and talk like them. Equity is built, not given. It's something that really needs to be built with the community, so that it is something that they can say for sure that is something that is equity, because without them being part of that, it's really hard to argue that this is a health equity program. Invest in local leaders, as I was saying earlier. I think that's a really important piece. And the last thing I would say would be that community-led change is sustainable change.
Thank you. Final word, Dr. Chin Hong.
Thank you. I think I just love the idea of ending on successes and solutions, like Dr. Turner Guevara said. So I love this last question because we focus so much on the negativity, but we've achieved so much, particularly in California, I feel. So to me, the two things that I think about that was successful was alignment. In California, for the most part, public health, politicians and academia, we all came together. And, and then the second was messaging. So I think after fumbles in the beginning, we developed, to Dr. Turner Guevara's point, individual messaging to different communities and not treated everyone like a monolith. And I think that really helped over time gain trust. So I think if we can remember these lessons, and I think a lot of minority populations got vaccinated for the first two, but we've fallen apart in the last, for the more recent shots. So I think coming back to some of the successes will help us all.
Fantastic. So many headlines here in these in this hour. Thank you all for joining us, and we'll see reporters next Friday. Take care.